Creating an Equitable Future of Health panel. My name is May Kwong. I'm the Executive Director at the Center for Connected Health Policy, which is the National Telehealth Policy Resource Center. We have a great set of speakers here for you today. I'm going to introduce them very quickly, but then give them an opportunity in a moment to also elaborate on where they're from and who they are. To my left here, immediately, I have Rebecca Flournoy, who is Senior Health Policy Leader at Kaiser Permanente Institute for Health Policy. We have Abner Mason, Founder and Chief Executive Officer of Same Sky Health, and Andy Martinez-Patterson, Chief Executive Officer for Alameda Health Consortium. Attending the conference today, I was really surprised to hear how often telehealth was mentioned. If you had asked me about maybe 5 years ago where telehealth would be in 2023, I would say probably on a slow and steady path. Definitely COVID-19 has changed everything and made telehealth a main topic now in our healthcare services. And what remains now is, where does it go next? But also there are other questions that are surrounding telehealth as well too, and that's also around equity issues regarding it. Whether telehealth creates an unequal environment for certain populations, or is it a great equalizer? And the answer could be that it can actually be both, depends on the case. So we're gonna start off, each of us is gonna take a couple of minutes and talk about our particular organizations. I'm going to give a little bit of an overview on where we are on the telehealth policy landscape, and then we're going to have like a conversation among us about the equity of telehealth. But we'll also leave time at the end also for your questions, so please keep that in mind and start preparing questions that you may have for our panelists. So very quickly, I am not a tech person. I am an attorney. So I start off with disclaimers every single time. So this is not like legal information or a legal opinion for you. It is strictly informational and educational purposes. Also, I have to say this because if I have to mention a company or show some type of product, neither I nor CCHP has any type of affiliation, arrangement, or relationship with such a company. I'm going to do this very quickly, but feel free to ask questions of me later or go to CCHP's website. But overview, on the federal level, as you know, when COVID-19 hit, a lot of exemptions were put in place to allow telehealth to be used more robustly to provide healthcare services. And a lot of those changes happened in Medicare, though there were other federal policies that were impacted as well, such as HIPAA or prescribing controlled substances. But most of what we saw were changes that were temporarily made to the Medicare program. So what do we know is going to happen once the public health emergency is over? And when I prepared these slides, I did not know the exact date, but now we do have an exact date of May 11, 2023, of when the federal public health emergency will be declared over. So what's going to happen around that is that some of the temporary waivers on the federal level with Medicare are going to stick around for about 2 years until the end of 2024. And these are some of the major ones in Medicare, such as allowing telehealth to be used and you don't have to be in a certain geographic location or a certain type of healthcare facility site. Still continuing to allow certain providers to be telehealth providers in the Medicare program, such as FQHCs and RHCs and PTs and OTs, and still allowing audio only to be used to provide some services. Some things will not be around once that public health emergency is declared over, such as prescribing controlled substances without having like an in-person visit with the patient and that telehealth provider and fitting into one of those narrow exceptions. That will end immediately after the public health emergency is over. Now, there is talk about certain ways to maybe extend that, such as creating a registry for telehealth providers, or perhaps an exception for prescribing buprenorphine to treat substance use disorder. Right now, what we know now is that that is definitely one thing that will end. And a couple of other things will end as well, too. But this is a situation on the federal level, which basically buys them some time. So there's going to be the question of like, are they going to move to a more permanent resolution, or do we just have this 2-year temporary extension? What happens to California? Now, California and actually a lot of other states have been moving along a lot more robustly or a lot more decisively over the last couple of years than what the feds have done. And a lot of states have already made their final decisions on what it's going to look like with the public health emergencies declared over. And California is actually one of those states, and California has actually kept around a lot of their temporary policies that they enacted for COVID-19. Now, before the pandemic happened, California actually had just updated their telehealth policies in their Medicaid program literally 5 months before the pandemic hit. And it was a pretty robust policy, but even then, they needed to do some temporary waivers in order for telehealth to be used a little bit more broadly. And they're keeping a lot of those around. And one of the big things is still continuing to allow audio only to be used to provide some services as well too. They've also made a couple other things permanent, such as allowing a little bit more latitude for FQHCs and RHCs to use telehealth as well too. But they've also changed a couple of things as well. So such as being a little bit more explicit in what you need in the consent when you get that from the patient before they have telehealth services. They also added these other policies as well, such as saying that no sooner than January 1st of 2024, if you are a 100% exclusive telehealth provider using live video, by a certain date, we're going to require you in the Medicaid program to actually have an in-person service ability as well too. So some sort of brick and mortar way of providing services in person. Or be able to like facilitate those services for the patient if you don't have like that in-person services. And if you're a provider who is just strictly audio only, you're supposed to have like a live video service as well too by a certain date. Now they said no sooner January 1st, 2024, so this could be something that's a little bit more in the future, 2025, but we know that this is something that the Medicaid program in California is going to require at some point. And then another thing that they did was require a research and evaluation plan that the department has been working on. They issued their plan, a draft of it, of parameters of it, like back at the end of last year and what they're going to look at. And basically it's getting at that big question that we always talk about, data. Like what type of data do they want to gather? What type of data are they going to be looking at for this Medicaid program around telehealth? So these are some of the major things that are still going on in California. But for the most part, in California, they probably think a lot of policymakers and probably a lot of people in the telehealth field think we've done a lot already. So there's probably nothing more we need to do. But we're going to have that discussion on this panel. Is that really true? Is our work really done? And is telehealth policy really settled in the state? Or is there more things that we need to do? So this is a CCHP website. I'm going to turn it over to our first speaker, who is Rebecca.
All right. Hi, everyone. It's great to see all of you. So I am with Kaiser Permanente, and to set up our conversation, I'm going to share just a little bit about our experiences. If you can go to the next slide. For those of you who are not familiar with Kaiser Permanente, we have 12.6 million members that we serve as a health system, and you can see the different areas we're located across the country on this map. Next slide. So I am part of the Kaiser Permanente Institute for Health Policy, and we work to shape health policy and practice, and we often do that using the evidence and experience from Kaiser Permanente to add to policy conversations as the nation's largest private integrated care organization. Next slide. And I want to talk a little bit about what I mean by integrated care in the context of Kaiser Permanente, and particularly in the context of the telehealth conversation that we're going to be having today. So at the broadest level, what that means is we are a health plan and a healthcare delivery system all under one roof. But there are some specific components to that I think are worth emphasizing. One is that we really focus on coordinated care. So just in general, if you're seeing several different providers about different health care issues you have, they're going to be able to see what your conversations with your other providers so that they can provide care for the whole person rather than disconnected care. And so in the context of telehealth, what that means is it's not a situation where you talk to a telehealth provider and then your main healthcare provider has no idea what happened, right? So you can call and you can book an in-person appointment, you can book a phone appointment, video appointment, you can send an email to your provider. If you want to get in faster with someone, maybe to see a doctor that day, you can book a telehealth appointment with someone else, and that information will go to your primary care provider. And so it's really that level of coordination that we think is allows us to provide telehealth care that's part of your overall care. The other thing that I want to reference related to our conversation today in terms of our integrated care model is that because we collect premiums in advance, and then we can use that pool of resources to deliver care in the way that makes sense. So that is going to be direct healthcare services when folks need them, but it's also going to mean focusing on prevention. And in the case of telehealth, it actually allowed us to invest early in telehealth services because we saw the direction things were headed. We knew that people wanted really accessible care, really convenient care. And so, next slide. So what you can see in this chart is this is since 2012, and this is email and phone as a percent of total outpatient visits. And what you see is we were steadily increasing the amount of telehealth we were using, and then the pandemic hit, and then it spiked up, and we were really glad that we had made those investments and that so many people had already been using telehealth, and those who hadn't, we were able to get up to speed really quickly. Next slide. So if we look in a little more depth in terms of what happened that first year of the pandemic, a couple things I want to highlight in this slide. One is that you'll see that, there was a period that first year of the pandemic, right, where nobody wanted to go in person to see their doctor. So we saw email, phone, video visits spike up. And I know, because I've seen more current data, it's come down some, but it's higher than it was before the pandemic. The other thing that I want to highlight that I think is really important about this chart is that light blue line across the bottom is video visits. Video visits increased by a factor of 28 times, so huge increase in video visits. But at the same time, notice that we're doing far more phone visits, emails, other kinds of care. And so I think that's important to note for a conversation that we'll have later. Next slide. And then I definitely think we'll get a chance to touch on this in much more detail, but Kaiser Permanente as an organization is very committed to health equity in everything we do, and that includes focusing on digital equity. I think more and more care delivery is going to be about having options that include telehealth options, and so making sure that everyone who wants to use telehealth is able to do so. And so we need to think about what policies do we need in place to make that a reality, and also think about digital access in many ways is a social determinant of health. Some people refer to it as a super social determinant, right? It's going to affect your ability to apply for jobs, your ability to do schoolwork. It's, you're going to be reading books from the library potentially on digital devices. There's going to be more and more of this. And so how do we leverage the opportunity that we have right now to advance equity? Thank you.
Abner?
Sure. So I'm Abner Mason. I'm a founder and CEO of Same Sky Health. We are a health tech company, a venture-backed company. I started about 10 years ago, so we're celebrating an anniversary, 10-year anniversary this year. So I'm happy to be able to share some of how we are working with our health plan clients. So we work primarily with health plans, helping health plans to engage their members in a way that drives health equity and that builds trust. You can go to the next slide. So we are a cultural connections company at Same Sky Health. We believe that the way to build a more trusted relationship with health plan members, and again, we work on behalf of the plan, typically white label, so we're reaching out to the plan's members, trying to engage those members and to ultimately convince them to come in for a wellness screening, or bring their child in for a well child visit, or to do a diabetes screening. So we're trying to help our health plan partners to improve their quality measures, so we're trying to prevent gaps in care, and also address health equity. And across the lines of business we work in are Medicaid, Medicare Advantage, and Exchange. We're not in the commercial space yet. So it's the government programs that about half of Americans get their coverage through those programs. We work with many of the larger plans in California and with 7 of the largest health plans across the country. So we're learning a lot over the last 10 years. What we've learned, key to this is that if you want to build trust with members and with patients or members, treating them all the same is not the way to do it. And what we have found, and in fact that's why I started the company, is too much of healthcare in America has a sort of one-size-fits-all approach. And that approach is increasingly not working. One of the reasons it's not working is because, we're increasingly a multicultural country. We're on the way to being a majority-minority country. California is today already a majority-minority state. But you would be surprised, maybe some of you wouldn't, in that the way health plans and providers and other healthcare stakeholders engage their patients and members is all too often kind of a one-size-fits-all. And what we found is that if you take the time to understand who people are at a deeper cultural level, you can build trust and you can navigate them into healthcare at the right time and at the right place. The other reason that it's increasingly important to recognize that a one-size-fits-all approach is not going to work is we have always known this, but I think it's becoming clearer and clearer to us that the social determinants of health, and you just mentioned this, have a profound impact on people's health. Depending on what, who you're getting the information from, people say it's 60, 70, 80% of a person's health are those factors outside of a doctor's visit or a clinic visit. And so those social determinants we know now they play a much bigger factor. And that's another reason why the whole concept of sort of treating everybody the same. And I have to emphasize this. Healthcare today largely treats people the same. If you're in a health plan, and for all the guys in the room, if we're the same health plan, we're getting the same engagement. They're reaching out the same way. It might be a little different for men versus women, but you'd be amazed how similar it is even between men and women, because that one-size-fits-all approach is how our healthcare system has developed. What we found, and this is the key finding, you can go to the next slide for us. I guess that's the last slide. So what we have found is that if you take the time to understand who people are at a deeper cultural level, if you build a technology platform, and that's what we've done, that allows us to ingest that data, public data, private data, claims data, we add to that a team of people who understand how different communities consume healthcare. What we're able to do is to create an individualized experience so that when we reach out to health plan members on behalf of the plan, we call it an N of one experience. Based on how that person starts to respond, their journey the rest of the year changes. We have learned, for instance, that it's no use talking to someone about a diabetes screening if they don't have food in the refrigerator. It makes much more sense to find out if they've got food insecurity, help them with that issue, that SDOH issue, and then talk to them about why it's important to come in for a retinal exam or a foot exam. So that's just one example of what we have found is that by treating the person as a whole person and using technology to understand who they are at that deeper level. And I always reference this. Some of you probably have Netflix or you have shopped on Amazon. What you find is that very quickly those elsewhere in our economy, we start to treat people like they're different. So I guarantee you, if in your house, if you have Netflix, your list of preferred shows and recommended shows is different from the people who live in your house, because they understand that if they treat you all the same, you're not going to use their service. You're going to say, when you treat everyone the same, what you're saying is who they are doesn't matter. And when you treat people like who they are doesn't matter, you don't build trust. And you don't take into account that we all have a different life journey. We have a different level of trust for the health system. We have a different ability to engage in healthcare. The social determinants affect each of us differently. So what we've done, all we've done at Same Sky Health, it sounds simple, it's not simple, but it sounds simple, is just use technology in much the same way the rest of the economy is. That's why I reference Netflix and Amazon and Google. I'm not saying they're perfect, but that is the direction that we have to take healthcare. And we have to get away from the one-size-fits-all. We do a lot of testing, and that's an example of how we A/B test all of our content. And that approach, personalized, N of one, connecting with people based on who they are culturally, it really does build trust. It allows us to close gaps in care. It allows us to collect race, ethnicity, and language data at a much higher level, SOGI data, sexual orientation, gender identity data, and SDOH data. And it allows us to then start to analyze that data and stratify it based on those demographics. We're identifying the disparities across those demographic groups, and it gives us, for the first time, the ability to help our plan partners to really target programs and funding to reduce those disparities. The bottom line here is that if you treat people like who they are matters, you use technology to do it at scale, and you make sure that you're analyzing that and stratifying it for the demographics, you can start to close those disparity gaps, and you can create a much more equitable healthcare experience. That's what we're doing. We're doing it at scale, and we're getting really good results. So I'll stop there because I'm sure we'll have other topics.
Thank you, Abner. Andy?
Thank you. So I think I'm here for the voice of patients. Do they like it and does it work in the low-income communities? And the answer is yes. So I'm 7 months a baby of the CEO at the Alameda Health Consortium and Community Health Center Network. We are a consortium of 8 community health centers in Alameda County, 340,000 patients, about 1.5 million visits. You can see how racially and economically diverse our patient population is. And prior to being a baby, I was an old person at the State Association here in Sacramento, really working on telehealth for a really long time. And I would argue, in addition to what Abner was talking about adding technology, identifying who the patient is, it's so much about payment. The reason we haven't done telehealth pre-COVID is because we couldn't get paid for it, and we knew forever that it would be better if we could provide telehealth to our patients. But health centers, of which my entire membership is, have these rules in Medicaid that you can't be paid for, you have to only be paid for a visit with a doctor inside of the physical 4 walls of a health center. So, and we knew it. I mean, I, as somebody who's an immigrant into California, didn't know anything about, I only knew PPOs, found Kaiser because of telehealth, and was like, and I had 2 babies and was using the advice line all the time, and I thought, if anybody in the whole world needs this is low-income patients who a community health center serve. Oh my goodness. And did it work with COVID? Absolutely, the patients really liked it. That's what we did, the survey that we have here that we'll show you a little bit more about that. They do really like it, and we knew it forever that this would be better for everybody. Is it true that you have issues of technology? I mean, I have issues with technology. I don't know who Zoom breaks their computer all the time. Mine does. So to the point on phone calls being so much better, but it helped with no-show rates. We have had huge issues with behavioral health and bringing people in for cultural reasons, gender conformity, like all these reasons people did not want to access behavioral health. And all of a sudden we had health centers saying their no-show rates of 45% dropped to 0 because they could have a phone call and they could take a walk. They didn't have to be with their family. I was just at Asian Health Services this morning, and the head pediatrician was talking about how important he finds telehealth because he can see the house. He can see where the kids get to play. He gets to see what's in the refrigerator because he asks for a tour. Whereas in the health center, it's a controlled space, and the patients conform. The parents conform, the kids conform, they're uncomfortable. And I've heard it both ways, right? I've heard in the Central Valley, still being connected to the health center statewide, a lot of the patients at many of the health centers in the Central Valley don't like telehealth. They need to physically see their provider. They want to do that. I do think there's somewhat cultural elements there. There's age differences there. The younger our population becomes, or they start coming up, they're gonna want more telehealth, and we want to adapt and conform to that. And we also have ability just with translation that we can do so much more with technology. And would just note, as we wanted it forever, we pushed for policies. I worked with May forever, trying to get policies to make it work. And it took what felt like 3 years, it was only 3 days of begging Medicaid during COVID to get payment, and health centers turned on telehealth within days. And we knew, everyone said that they couldn't do it. I promise you, if we had tried to come up with the policy on how to do it, it would have taken us 5 years. But with COVID, it took 3 days, and health centers went from no visits, no revenue, because you only get paid in the 4 walls of the health center, to all of a sudden coming right back. And we're always almost right back to where we were statewide, and you'll see that in Alameda too. So we knew that it was a policy barrier and a payment barrier. That was the main cause, and that patients actually really liked it. So what you'll just see in here, we did a really quick survey of our providers and our patients in Alameda County, and it improved access to care. It had more ability to focus on the patient, and it actually improved the patient and the provider relationship because of the flexibility. None of this is surprising to you. This is just all confirmation, which is really fun to be a policy wonk, than saying, see, it wasn't just a theory, we knew it was gonna be true. The no-show rates dropped. People appreciated more flexibility. One thing that I think is interesting is that where the paternalism is why we weren't able to do it, right? Because the state, the payer, doesn't trust that some weird shenanigans can't be going on. You're just doing FaceTime all over the street, billing for Medicaid, right? Horrible fraud could happen. Where was I going with that? What a fascinating thing to say. But, I was talking to some of the health centers in the Central Valley, and the providers there, they don't like telehealth. They really want the patients to come in because they want to touch them. But they're not responding to or that they need to have them impaneled, and they can only see their provider. And their provider has a wait time of 4 weeks, so they can't allow for that there's, as much as there's a paternalism on the payer side, our own system is going to have to adapt that while you might want to see your same doctor for your diabetes on a regular basis, when your baby has a high fever, you just need someone, it doesn't matter who it is, immediately in the middle of the night. It doesn't matter. And then even our own system is going to have to kind of break free from only I can take care of this patient. I think telehealth really opens that door that we will have to do our own cultural reckoning with, all for good intent, but we have to keep putting the patients at the center, and I think telehealth enabled us to do that. The next slide just shows you a percentage. 56 prefer it, which is not a surprise just because it's so much more convenient. Every single one of us have experienced this. If you've had access on telehealth or something, or you just are an Amazon Prime member, it's amazing. You just get it as fast as you want. And I think it's crazy to assume that in Medicaid or in Medicare, when everyone has access so cheaply to such quick services, tailoring of Netflix, that when the healthcare system does not conform, you will lose so quickly in that space. But we're more bureaucratic, we're heavy, so we have to figure out how to be a little bit more nimble using technology. And then patients just like having more ability to see. And we even have one of the new, it sounds crazy that this is kind of an innovation, but it's an innovation for us because of our payment mechanism. We'll have patients come into a health center with a nurse. Nurses are not billable in our environment, so you're just kind of eating that cost. But the provider can be in Hawaii, and we can bill for it with telehealth. And that gives us, because it's really hard to recruit providers into the safety net system. So if you can say you can work from anywhere, on Mount Olympus, like we'll still help you. Like we'll make that anything work. That's so helpful for us. And then we can see more patients and allow more flexibility for the providers. Let's see, keep going. Yep, so this is just more confirmation. And then in terms of barriers, continues to be, any barrier on payment, so immediately links to alternate, for us in the FQHC world, it's called an alternative payment methodology. In private world, it's capitation, so that the plan says, here's $50, do with it what you will, I hope you don't spend 100. And if you spend 30, you get to keep 20. So we're trying to move into that environment in the health center world so that you have more flexibility and the payment isn't the barrier. And I would also say we do have patients who have limited minutes, right? They buy minutes. They are not going to be able to do video visits. We have some patients who live with multiple families and it's not private enough for them to do it. We have to figure out all of those pieces. And then of course, because we had to turn on telehealth so fast, most health centers had some kind of a tech equipment stuck in a corner that's a grant, a really generous funder in California paid for, couldn't figure out how to make it viable because we couldn't get paid for it, so it sat over there, and then all of a sudden had to dust it off and see if it still worked during COVID, and everyone was doing FaceTime. Thank God for the iPhone, right? Everyone was doing FaceTime, which was allowed, which was great, but our technology just has not kept up. I would say I've seen this in all of associations and meeting spaces. Everyone redid all of their technology for sound and video because none of the technology we had kept up, and health centers don't have a lot of capital for that. So we do have to up the technology and the spaces, right? Spaces for technology just need to be rethought, and we, again, don't have a lot of capital, infrastructure, resources to be able to do that, but that's gonna need to happen too. But it's not going away, and the patients really, really want it. And I think that is all the obviousness of what I would tell you. Everything you thought is on these slides. And the patient said it, and the doctor said it. And the pro-con, right? I still run into providers who are like, it's just not the same, I need to touch them. But the benefit to the patient is so much more, and they're willing to have it be good enough. Not perfect, but good enough, because there might be a little bit more flexibility in a provider schedule in telehealth than in the exam room, where they don't even have enough time and they didn't notice, right? Like we believe that we're perfect in the exam room, but that's not actually true either. So telehealth is just now gearing healthcare more to the patient as opposed to the provider, which is the direction it should probably go. Thank you.
Thank you, Andy, and thank you all of our panelists here. So as Andy mentioned, the two of us have been at this a long time on telehealth policy. And as I mentioned earlier, on the federal level, and definitely on the state level here in California, there's been some significant changes in the past couple of years, especially California with last year. Now, the sense is probably with some policymakers is that our work is done. We've addressed this telehealth policy issue. But is it done? Is there something more that needs to happen on the policy level or in other ways in order to make the policy that they pass actually work for the people it was meant for, the providers and the patients? So Rebecca, do you want to kick us off on that?
Sure, I'd be happy to. I think it's interesting thinking about what we've all been through these past couple years with the COVID pandemic. There's a lot of attention right now to digital, right? But we also know that things change and that attention may not be there forever. So I think there is an opportunity to keep pushing. We heard the panel earlier this morning talking about broadband and the importance of that. A few takeaways that I would just underline for that. I think one is it's definitely a rural issue and it's an urban issue. And I would also underline it's about, do you have the actual infrastructure so that you can get services, but it's also about affordability. If you technically have access, but you can't afford it, you don't really have access. And so I think we need to keep an eye on that. There are some subsidies that are available for broadband for devices, but there's not enough to meet the need, and the world is just going to be continuing to get increasingly digital, and so we want to figure out, how do we use this moment to capitalize on that and to keep pushing forward. The other piece that I will highlight is, I think, it's good to see that at the federal level and in California too, that we're covering phone-based services in addition to these other services, since we know that broadband devices can be an issue. And I think we need to keep tracking, is that working for people? And if it's not, what do we need to adjust so that it does work for folks? I think at the end of the day, what we're trying to set up is choice for everyone. You can see a provider in person, you can use video. Sometimes even if you can use video, you just rather do a phone call, and we want to give people that option, right? So I think we need to keep that in mind too, but be really thoughtful about measuring how we're doing and looking at equity issues, and who is this working for and who is it not working for, and how do we need to adjust given that?
Abner?
Sure. So I'll just to follow up on your point. When COVID first hit, my company, we were working with health plans and also some of their provider networks. And so, to your point, they were FQHCs. This is Medicaid or Medi-Cal. So FQHCs serving Medi-Cal patients. They had never done telehealth before because they couldn't get paid for it. All of a sudden, overnight, they had to turn it on. And so our job was to reach out to the patients of those clinics and to tell the patients there is a way for you to get health care, even though the clinic, you can't go to the clinic. You can see your doctor or have a consultation with the doctor virtually. And I think in the first 4 or 5 months of us doing that, we must have generated about 40,000, 50,000 visits for the network of the FQHCs that we worked with. Interestingly, overwhelmingly, those folks preferred phone. Like it was, I'd say, 75, 80% preferred phone to video. So I think we've got to make sure, and I think it's a good thing that California is continuing to have parity, but it's an issue, and my concern is that going forward, what we know in healthcare that what you reimburse for, you get more of it, and if we end up in a place where we reimburse for video higher than audio, just phone, which I fear. I'm glad that we're holding on for the moment. Many other states aren't. We're going to end up tipping it so that providers are going to end up doing what they get paid for and what they get paid more for. Even though the patient wants a phone, we're going to force them to use video, and people vote with their feet. Really, they're just not going to do it. And so now I know people say video is more robust and it's better, and there's all these things that video adds that have that the voice doesn't. I'm not going to argue that point, but I love what you said. Voice is good enough. We can't let the perfect become the enemy of the good. And we should prioritize what patients want, what people want. And if they want voice, we shouldn't, force on them something they don't want. So I really think that the data is supporting that. The other quick point I'd make is when we started doing that work, we reached out, as I said, 50, 60,000 visits just in the first 4 or 5 months of COVID. And we did all of that work, or at least 90% of it, by texting the member, the patient. We were working on behalf of the plan. The plan was paying us in partnership with the FQHC, but we were reaching out to the patient via text message. What we have found is that is the preferred way that people want to communicate, two-way text messaging. If you are sending U.S. mail, you may as well forget it. I mean, it's just, particularly for Medicaid and low-income people. And if even email doesn't work, people prefer text messaging. I would ask you, I don't even do it, but sometimes I ask people, how many of you communicate with your family and friends via U.S. mail? No hands go up. When I say texting, that's the way you communicate. I mean, that's the way America works today in 2023. And yet health plans in California and in other states are constrained and unable to engage their members via text message because of an old federal law called the Telephone Consumer Protection Act. It is kind of a scandal that we're in 2023 and most health plans, particularly the big ones, won't text their members, particularly Medicaid folks, and it's the only way they're going to communicate. Now, we had one piece of good news that happened in the last couple of weeks. The White House, HHS had to write the FCC, and the FCC finally, after months, ruled that purely for the purposes of redetermination around Medicaid members who have to be redetermined, health plans can text their members. Now think about that. This is 2023, and we had to get the FCC to rule that plans could text their members when that's the only way their members are going to communicate. So I do want to say that's a good thing. I'm glad that it happened, but it's a baby step in we shouldn't even be dealing with this issue when that's the only way that people are going to communicate. So when you say the question, is there policy? Much of what we want to do to become more digital, the way we're going to achieve that is by connecting with people, and the only way to do that is digitally. It's going to be through text messaging. So we've got a long way to go in California because for redetermination, we can do it, but health plans in California today, Medi-Cal plans, particularly the big ones today, still will not use text messaging, which is the preferred way to communicate that the members want. They still are constrained.
Andy?
Yeah. I can't help but reference this. So I was just driving up from Alameda, and I get to listen to lots of podcasts. So the podcast I was just listening to was Ezra Klein, and they were talking about basically like the problem with liberalism and that liberals have gone too far, and I'm not assuming you're all liberals in any stretch of the imagination, but too far on controlling government with regulation, and we're not willing to deal with it. And these are all we make it illegal, like on a housing, but we make it illegal to actually build apartment buildings. We make it illegal to pay for, we say $5 for a telephone, $25 for a we just put all these regulations in place that prohibit all creativity, and then we expect the safety net to compete with Kaiser, which is just craziness for us to be able to do that. And we can't, we are regulating ourselves into a lower tier healthcare system because we're competing for the exact same staff. Our patients are experiencing Amazon has a $19.99 a month health package. I would definitely do that if I was low income. I would absolutely do that. And we're gonna miss out on a lot of services for these folks when we have now at the same time acknowledged consumer choice. And we're also saying, and ACEs. Amazon is not going to deal with ACEs, adverse childhood events. They're not going to deal with social determinants of health. Health centers are the ones, in my mind, this is why I got into this movement, was for the community, wrapping around the community, coming from the community, but we are prohibited by old rules and regulations and brick and mortar and our own feeling of having to touch and not having technology. So it's a pain, and to your point, health centers started building latrines and giving people food in Mississippi, and then we got paid for Band-Aids, so we said, okay, well, we got to buy a lot of Band-Aids and a lot of doctors, and we stopped building latrines, we stopped doing food, and you just follow where the resources go. And if we don't shift the payment and we don't ease up on the paternal nanny state infrastructure, and I do support government, I understand the reasons for it, but we prohibit all innovation, and then you will just kind of wipe out the safety net, and no one will want to work there, and there will still be this huge bastion of people who need extra services, and there won't be anywhere to get them. but they will be able to get, you know, a phone call for $19.99 a month and feel a little bit better, but they will still have a whole bunch of needs that they need. So payment and then deregulation.
You know, it's interesting listening to these comments here because what, especially Andy, you and Abner touched upon, are not telehealth policy issues. It's like larger issues. So a lot of times when, and I'm sure you all have been in this situation when you're talking to a policymaker and you're talking about telehealth, they're like, well, show me the data. But is that the data that they really need to like see and like enact changes? So that's my next question to you, especially since Medi-Cal has this research and evaluation plan. What type of data should they be collecting in order to like enact these changes that, you know, really would push the system forward?
Anyone have a ripe response on data? What do they need? I mean, patient, yeah, the hard part, like I want to tell you patient experience. But I might say, so there on one of the slides that I have says 1.5 million visits. That's actually our version of visits. It's not the government's version of visits. The government's version of visits is much smaller than that. And if you said it was touches, it would probably be 5 million. A touch being a nurse, a CHW, a walk with a CHW. Those don't count in the visits. It's really only a mental health provider or a doctor. Visits being, how do you engage consumers in healthcare would be a data point I would see. And if telehealth enabled deeper engagement, I would love to see too, I have to believe that Kaiser's nurse line decreases your ER utilization. And maybe it doesn't, but I would just presume that it does. And that having that ability to sustain something like that 24 hours a day dramatically reduces costs. And it doesn't have to, like, we should never be producing data on certain technology. It should be technology agnostic, and it should be flexible to whomever is delivering, and then measure them on quality.
Yeah, and since you mentioned Kaiser Permanente, maybe I'll pick up on that. You know, it's interesting to think there's definitely some really good research going on in different corners of the organization, and then I think there's that question of how do we get that to the policymakers who are trying to make the decisions, right? They're not reading the peer-reviewed literature because they've got a million different things that they're tracking, and I do think there's probably a need for more clarity on what are we learning and what are the implications of that for the decisions that they're going to be making. I also wanted to touch on Abner's point about the importance of kind of designing for equity and being really thoughtful about how we're approaching things. I know of different design teams within Kaiser Permanente who they do focus groups, they do interviews, they're trying to understand for different people all over the organization, what do they want, what are their experiences, what's working, what's not, and then using that to constantly adapt because we know technology is going to continue to change. So it looks like one thing right now, it's going to look like something else 5 years out. And then the last thing that I wanted to highlight in the research space, disaggregate our data, right? We need to understand not just does telehealth work, does telehealth work for certain health conditions? We need to know that, but we need to know for who, under what circumstances. If it didn't work, why didn't it work? You know, what does that mean in terms of what we need to do differently? What does it mean in terms of policy? And I think for all the researchers out there, I hope that you'll continue to push yourself to figure out, can we disaggregate our data to really understand at a deeper level what's going on, because we need to do that to promote equity.
And I would just add, I agree with both those comments, and just the importance of really getting serious about collecting, you know, real data, race, ethnicity, and language, and SOGI, sexual orientation, gender identity, and even SDOH data. I mean, it's kind of another, you know, I guess I'm talking about scandals today. It's kind of another scandal of our healthcare system that we have never collected that. The health plans we work with, and we work with the biggest ones across the country and in California, they don't have that data on their members. So it's really hard to know who a policy is working for if you don't have basic, you know, demographic data. And so I think that it's you know, it's high time that our country and our state, that we got serious about it. And I think there's some positive things happening. It's taken a long time, but we, you know, at the state level, they're now requiring plans to collect that data, and even at the federal level, they're requiring plans to collect that, and I hope that it happens in the commercial side as well. we're just not going to identify disparities and be able to disaggregate and know who's it working for and who it's not working for if we don't do that. And it's high. We talked about it for 50 years, long as I can remember, we talked about it. But basically, until this is one of those areas where regulation has to. I hate to say it this way, but it has to force the system to do it. Even during COVID, we didn't. You would think that would have been an ideal moment to really collect race and ethnicity. That it didn't happen. So, but I think there are signs that we're getting serious now. And I think that's a big step toward being able to disaggregate and really see what is working for who. And then the next step is, okay, we need new solutions. If we have huge disparities and we can finally measure them over time, we've never been able to do that, but now we're going to start, hopefully. We can actually measure over time. We can identify those disparities. As a nation and as a state, we shouldn't just say, well, okay, I see they're there, we're not going to do anything about it. It gives us a chance then to really address those disparities with new solutions, because clearly the existing solutions aren't working very well.
We've touched upon the patient experience in our discussion, and Andy, your group has done a survey saying that they really love it, but there's also been some maybe hesitation from providers as well into offering it to patients. What more can be done to have that patient engagement, that patient education? I know from my own experience when COVID hit, my parents, who are seniors, were switched automatically over to telehealth, and their sort of first introduction to it was not particularly good if I was not there. So there was the provider engaging with them. I mean, at one point, the camera was I could see up your nostrils, provider. So tilt the camera down. So those are, and I don't think that was an uncommon experience for a lot of patients, definitely in those early days of COVID. So what can maybe be done in order to get the patient more engaged in using technology and more comfortable with using technology as we move forward? Because that's definitely, as we talked about here, seems to be where the health care field is shifting over, because that's what they're going to need to do in order to continue and survive and thrive. So I don't know who wants to take that first.
I'm curious. I know that there have been, I think in our community in particular, it's very cultural. So it really matters that you're doing some amount of patient focus groups. And that, just as an example, unless you really ask in a patient focus group and not just a survey and not make assumptions, but at Asian Health they have 13 different languages. And in the waiting room they decided to add 4 different Asian languages, and they just added Tagalog. And even though most of their Tagalog speakers speak English, they learned after a few months of not very high utilization that they're more comfortable in their native language. So they added that. They brought in a staff person who could speak it, but they only knew that from watching their data and asking lots of questions. I think for the older populations, you need in an in-person visit to teach them how to use it and how to feel comfortable with it. And then there's younger generations that don't. I know I've definitely seen lots of my personal experiences, lots of tutorials and different setups, but you do have to have some kind of a stomach for technology to download the apps and do all of that. I don't know that there really is a super easy way to do it. I'd love to see if there is, but I know in the health center world, we definitely need more. We're trying to figure out what's the best workflow. What's the best way of communicating? Does someone else come on the phone and then you hand it? We're still testing all of those things. So part of it, I think, is just sharing best practices and trying different things. And then it's really cultural, and then sharing that across.
I'll just add that I think one element that needs to be involved here is technology companies, and I'm pointing at myself, entrepreneurs and people who are building technology. One of the things that I think if you can sort of envision, close your eyes and think 10 years from now, you could really see a point where the typical visit is a virtual visit. It's in the home. There's a number of devices that are in the home that are easy for the person to take blood pressure and oximeters and various devices that they're available today. I mean, it's just that it's not, the ecosystem hasn't been built out in a way that really makes it easier. But if you can imagine, it's probably not even 10 years, probably 5 years, that you could do almost as much with a visit with some devices in the home that are connected as you could going into a clinic. That's the future. And that's coming whether we like it or not. And so what we've got to make sure of is that those technologies are being built in a way. So it's a telehealth visit, but it's a much more robust visit. It's connected devices. It's remote patient monitoring. All of these tools, they're coming, and the issue is, will they come and be available to everybody or just higher income people? And I think we need to make sure that we are always saying and pushing for, and regulation has to require some of these tools to take into account the kind of design that you were just talking about, where it's designed for everybody, including seniors, not just higher end folks who are really comfortable with technology. Because I don't mean to be negative here, but you could, as brick and mortar becomes more expensive, you could really see a day very soon where a lot of the brick and mortar closes. I mean, look at Sears and look at, I don't need to tell you all the stores that have closed because of online solutions. Well, that's going to happen in healthcare, and I hope that we can save the community health centers and FQHCs. But a lot of the brick and mortar goes away, and when it does, the only alternative is going to be virtual care. And if we haven't built the virtual care solutions so that they work for everybody, we're going to reinforce all of the health inequities that we're talking about, trying to get rid of. They're right around the corner if we don't get this right.
Oh, sorry. So just to on this question, before we pivot to the next conversation, so Kaiser Permanente provided support to the Virtual Care Innovation Network during the COVID-19 pandemic to help safety net providers scale up. And there was a study that was done to sort of what were the learnings. And I think it emphasizes some of the themes that you've heard here. Most visits were audio visits. Integrating interpreter services, really important, and it's something that we do overall in our system as well. And then there were a lot of sort of tech and workflow and staffing challenges, right? This need for digital navigators to help folks get set up. There was a study that came out recently within the past few months from Kaiser Permanente Northern California researchers that they found that if there was an assistant who checked in on folks before a video visit and kind of checked in and said, hey, are you all set up? Do you need any help? And then the visit happened, it made a huge difference, right? So, but I think it's one of these areas where we're sort of building the plane while flying it, which is always it feels a little terrifying, right? But we're sorting it out as we go. And so I think we need to keep looking at what's working, what's not, and learning from each other and sharing that information.
Thank you. We are now moving over to questions from the audience. Hopefully you guys have been thinking about that. And we have a microphone here, or if you want to just yell out, we can.
I have a pretty loud voice. I'm Patricia Tanquary. I was the former CEO of Contra Costa Health Plan, contracted back with Kaiser. My husband's a retired Kaiser physician. I think everything that people said is true. I think there's one very big missing piece. We're not talking yet about outcomes. Mm-hmm. What are we missing with the dementia, with the hard of hearing, with some of the others? We have to think about what we're doing with Calais. We're building an important system. As we maybe get rid of bricks, mortar and bricks, and yes, it's cheaper, I really worry about just assuming we're going to eliminate all of it. The trust issues are real. Many older people, we couldn't make video call work with Kaiser. We gave up and said, we're coming in, okay?
Yes, and that's okay.
Come here anyway.
You can do that, yes.
So,
Yeah.
I think all is true.
Yeah.
And I would hope that we would not eliminate and that we would not ignore what are the diagnoses, what are the conditions. I mean, that's like advice nurse is wonderful because they have very well-developed protocols that keep having the review and have physician backup. I know I've used Kaiser's and I ran advice nurse myself at Contra Costa. But the outcomes of when these types of visits are really working, separate from, not that it is not important to know patient experience and patient satisfaction. They're saying audio for two reasons, I think, maybe three. I mean, one, everybody has it and it's okay. Two, I didn't put my makeup on today. I don't want my doctor seeing me looking like this. So I'm gonna do the audio. And three, maybe because, you can't get in. But what's being missed? What are the outcomes telling us? And I think certainly Kaiser is situated to do that. And maybe with your work with so many clinic visits, we can add to the perspective for that future. There shouldn't just
Yep.
be an elimination and there's only one way. We've been talking today about choices, and I would hope we would get to be informed choices, because as a consumer, if I knew that with certain kinds of conditions, even with the dementia and the cognitive impairment that happens with older people, it's worth it to come in, or it's worth it to try to struggle to get that video, that would be important
Yeah.
for me to know. I
Yeah.
might make a different choice.
Great questions, and I think you raised two different points that I want to address. One is, what's the goal? What are we trying to do here, right? And so I think the goal is to have really high-quality care.
It should be.
Bottom line, right? And so we should measure outcomes, and whether you got there through an in-person visit, through virtual, through whatever, however you get there, but we should have really strict quality measures that everybody's expected to hit, right? So I think that's really important, the goal, and equity should be a core part of that, right? So, you know, we should measure for outcomes, and we should measure for equity. Second point is, at least for our organization, I think our vision is that actually, I don't know that anyone is ever thinking that it would go all virtual. I think the vision is, sometimes you need to go in person. Some things you'd rather do by video. Sometimes a phone call is fine. And we're measuring that and learning, right? So for example, we know dermatology, being able to like email a photo seems to be working really well, right? Mental health visits, we're actually surprisingly, people seem to love being able to do them from home. You don't have to drive all the way to the clinic. You don't have the stigma of maybe walking into the clinic, right? You're comfortable at home.
If you have privacy in your home, we're making a lot of assumptions about
No.
families living in a two-bedroom.
Yeah, no, but that's the reason choice is important, right? Because sometimes it's going to work for folks, sometimes it's not. And if that's not the thing that works for you, you should have the choice. Actually, I'm not going to do that. I'm going to do this other thing. So I think for us, it's about choice, and we want everyone to have the full range of virtual options, but it doesn't mean only virtual. So, but great questions.
Yeah, a lot of time, and Andy knows this, during this telehealth policy work that we've been doing for over a decade, it's that telehealth is not a new service. It is just another tool in the provider's toolkit. So just allow them to use it, and then it's down to the patient and the provider whether it's the most appropriate time to use it. So, are there any other questions?
Well, I just wanted to say, to Patricia's point about the outcomes, to me, it's the payment, because we haven't, while we measure outcomes, it's still always driven by, did I get paid or not? And if you free that up and you still hold them to outcomes, and I'll pay you a certain amount, but I'll watch you on outcomes, it becomes about population health. And then the screening starts happening. Then I start being much more comprehensive about it, and I think that's kind of the way to move people with a strength-based approach towards that, rather than the payment, or the by service. Yes, but I appreciate that.
Hi there, thank you. I'm Lynn Scurry. I'm with Partnership Health Plan, and have a lot of history in telehealth, and so love all of the comments. So one of the things that I think about too is we have counties in both urban and rural areas, and the provider shortages that most of the clinics are facing are years. They're years. It's going to take years to fill if that happens. So I keep looking at innovation and telehealth and just wondering what you're thinking about, maybe where the industry is heading and how we can use telehealth for in more ways than we are right now. I can give you some examples of just in specialty care. In some of the parts of our region, there are no specialists in a certain area, particularly rheumatology and endocrine. At least 50% of the visits are now done virtually. They're done quicker, and I think, we don't have the outcome data, but we access data in itself is pretty amazing at people getting care quicker. So just asking you for what you're thinking in a system that is plagued by workforce issues. How do we move ahead? What should everybody, the primary care providers be thinking about in ways to extend their resources.
This is why we've been, actually, it was the rural health centers that pushed us again. The rural health centers were the most frightened of this alternative. They were the most frightened of managed care. They were terrified of you at partnership. I remember those meetings. Don't have managed care come. And they're doing quite well with managed care now. And they were really freaked out about payment reform, the APM. But then it was the rural health centers that pushed on it the hardest because of workforce. But the chicken and the egg is that a lot of experts would tell you, and I'm curious, I'm dubious of this, that you have to be very sophisticated to take on capitation, and I just wonder about that. I think it's a hard, then rural's like permanently in a hard situation, because our rules, unless the payers decide to change it, and we know at the federal level, you don't touch, for health centers, right, that's like there's 30 million people served by health centers, you don't touch the holy grail, which is our payment system, without a massive riot across the entire country. And in a divided Congress, that's not gonna happen. And then it's fee-for-service rules, which is, we don't pay for nurses, we only pay for an MD, we only pay for brick and mortar, right? All these horrible rules. So the flexible payment methodology is better, but then there's a fear that there's not a robust data infrastructure and technology infrastructure in order to manage this, which I personally very dubious about, but this is a fun debate that we have with our colleagues in health centers, but that should be the way. Like if you could have, right, in other countries, you don't have doctors seeing everybody. We have community nurses. Why can't we move more into that direction in order to still serve patients in rural communities? The APM is really meant to create more flexibility there, but then you have to have strong enough data and a strong enough infrastructure to be able to maintain it. And so then the question is, how do we get them those resources too? And the last thing I would just say, I heard of this, I just met somebody who works at a company. It's primarily for adults with disabilities so that they can live at home, but that they've monitored, they basically like teched up the house. So if the stove goes on, a phone call happens, right? Like it becomes a little scary that technology is living with you and you're being monitored. But it's really amazing for families who have disabled adults that person can live on their own. That would be great for dementia, right? And we will not have enough, right? We are not talking about the fact that we don't have enough skilled nursing facilities. All that is about to hit us very soon. How are we gonna use technology to keep people in their homes and families, right? When you were taking care of your parents, it would be really nice to have some devices to check on them when you couldn't be doing that. Maybe they could do it better.
We are almost at time, but we're going to take one more question. So,
Thank you. I'm Vince Richardson. I'm with the California Medicine Scholars Program. Thank you as a panel. I really enjoyed the robust conversation you all provided the audience today. But also want to follow with these two ones we talked about, which I think is very important because I really want to highlight cultural competency on while we're improving healthcare outcomes. So part of the program that I'm with, we just had got underway this past June. Community College Pathway Program that's working with 4 major universities across the state, UC Davis, UC San Diego, UC Riverside, also UC San Francisco, and Fresno. So the program is geared to recruit, educate, and train community colleges from students from underrepresented communities to become primary care physicians. Most of the literature says that when someone that looks like you, speak like you, understand you better, provide you better care. And to build trust, that's another way to build trust. When you're getting service from who understand you. There's a situation prior to me taking this job. This worked for Department of Healthcare Services. We did a diabetic retinopathy study. So one of the Latino doctors told us, I understand my people very well. I have some patients come and ask me, hey doc, I just want to take my shot. I just want to get my shots and eat my food. He said, but what I did, due to respect, I had to see a podiatrist so he can ask that question. Are you in your eyes, routine exam, since you're diabetic. So you got him on the back end. He said some people probably weren't that sensitive, probably won't care. So we're not talking about building trust. I'm talking about the cultural aspect of it also, because that's very important, because that's another way to improve outcomes. And this program that I'm telling everybody about right now, like I said, it's just underway. All 4 universities geared to recruit 50 students per year to make that 200. And this is something that we got a lot of support from HCI. We're also trying to recruit Kaiser. I'll put it out there.
Let's talk, yeah.
The California Wellness Foundation. many others. So the point I'm making is that there are some programs, there are some places that are trying to address the shortages of primary care physicians that we have, because we do have a shortage, not just in California, but statewide, but we focus more on California, shall I say. And I think this is a start. But more importantly, this telehealth thing is very serious. It's going place, and I do agree with you, Abner. I think in 5 to 10 years, we're going to have people have kits in their houses
Yep.
where they take their own blood pressure and so forth.
Connected
Your
devices, yep.
Yes, because some of us are doing it right now.
Yep.
Yeah.
But I just wanted to highlight that, the importance of cultural competency and all this to improve healthcare outcomes as well.
Thank you very much, and thank you, everyone. Let's have a round of applause for our panelists who were great today. ITUP would like, if you could, to fill out an evaluation here. You just use the QR code to pull that up. So if you could go ahead and do that for them, I'm sure that would really help them out. But thank you, everyone, for attending today's panel. Again, thank you to our panelists, and enjoy the rest of the conference.
It's great.